So I'm going to review the two book chapters for this week's topic on um, tibial pilon and malleolar ankle fractures. Let's go through this chapter first. This is on distal tibia fractures and focusing more on the pilon fractures. So I think there are some good tips in this chapter worth reviewing. First thing is assessment. Right, so remember the soft tissue envelope around the ankle is relatively thin. You do have to be careful if you have a fracture that you cannot get nicely closed reduced, due to soft tissue interposition or whatever. You can potentially develop skin necrosis over an area of tenting, and around the ankle, big area of skin necrosis sometimes cannot be, treated very easily, ends up needing a flap or worse. So this particular case was an emergency just to get it reduced, and X-Fix was used actually to kind of get it in place. You can argue maybe that the pin was a little closer than it really needed to be. It might get in the field of where the your plate, if you can fix this, plate fixation might cross that area. Open tibia fractures are bad actors. Okay, they can do very poorly. You got to be really careful with them. Make sure you do everything you can to prevent infection. Emergent IND, blister control is important. Whatever technique you use, try to keep these from getting infected, whether you unroof them or leave them alone. Cherney classification is something you should be aware of. This is not the same Cherney as that we use for osteomyelitis. This is Harold Cherney from Hanover in Germany. But anyhow, the Cherney classification is classification for soft tissue injury and closed fractures as opposed to open fractures. Okay, so this is a classification that you will see people use. You'll read it in papers, so you probably should be familiar with it. It's shown nicely here. Okay, and then your Gustillo classification you should be aware of. So, kind of like we mentioned before, the foot position, I talked about this in some of the slides in the PowerPoint. Foot position at the time of impact can determine the type of injury. So here you can see a injury where the posterior cortex is still intact, right? But this was probably dorsiflexed at the time of injury, and you get anterior injury. Here, the foot might have been plantarflexed at the time of axial loading, and the anterior cortex is intact, and you have a partial articular fracture with it going out posteriorly, and you may have to fix this posteriorly. Okay, like posterolateral or whatever, some type of posterior fixation. Here's Rudy Allgauer classification. I mentioned Rudy and Allgauer in the PowerPoint slide. You should be familiar with the four principles I talked about for pilon fixation, Rudy Allgauer principles. Here's a Rudy Allgauer classification. Okay, pretty straightforward, 1, 2, and 3. I think you'll see more AO classification being used for these. AO is, A is extra-articular, partial articular for B, and complete articular for C, right? Same thing everywhere. Talked about circular fixation in the plateau. Remember, circular fixation is an option in the pilon as well. Remember, it's an area where you can get into a lot of soft tissue problems. Plates can get infected if you're not careful, so not a bad place to consider using circular fixation. Early ankle motion is not as critical as knee motion. Okay, if you have a little bit of a stiff ankle, it's not the end of the world with these injuries, whereas a stiff knee can be very disabling. So, fixing across the joint and stabilizing with here you can see a foot ring with pins in the foot. I mean, if that is needed and the ankle gets a little stiff, not the end of the world. Okay. Hope you familiarize yourself, if you're not already, with the anatomy, where the tendons are around the ankle, where the neurovascular structures. Nice. See, this is a nice example, I think, of 3D imaging, kind of giving you a good sense of the personality of the fracture. And this kind of stuff doesn't necessarily help you to tell you that there's a fracture. This helps you with preoperative planning. Okay, to understand which fragments are where, and I think, at least in my mind, I can kind of see things better than I can on a 2D X-ray, right? So here's some fixation strategy with some of the major fragments being fixed anatomically back to the shaft, and then with distraction and ORIF of the articular fragments, you can see fixation medially and anterolaterally. Okay. One technique that you can use, I mean, remember, when you have an A-frame or X-fix in place, some people like putting pins in the foot. You can also just create a sling and do something to just keep the foot dorsiflex without putting pins in the foot. Those pins in the foot can sometimes be painful for a while afterwards. Here you can also see a nice example of kickstand, right? Keeping the heel off the bed. Some of the frames actually may give you something for that. Here's an example of an open pilon fracture treated with, I&D, eventual ORIF, through an anteromedial approach. These plates actually still exist. These are non-locking plates, straight plates that you have to kind of bend to get them to fit. Here's an example of a posterior shearing injury, right? So anterior cortex actually might even be intact. Posterior cortex blown out, treated with prone approach, ORIF in the back, and direct through posterolateral approach here. You can see direct fixation posteriorly. Example of here you can see tension failure on the fibular side, kind of like we showed in the first set of slides in the PowerPoint session. The tibia is fixed through the anteromedial approach. Here you can see a pilon plate used contoured with locking fixation distally. Okay. Here you can see there's also a distractor being used to help get provisional reduction through ligamentotaxis to turn this mess into something you can actually work with and open the joint up for you. Here's an example of sort of the staged treatment and standard A-frame that many of you will see. Here you can see this is an open injury on the medial side, treated with initial external fixation and then going on to anterolateral fixation, staying away from that open wound here and fixing the fibula directly through the same incision anterolaterally. Okay. Another case just showing anterior and medial fixation. Here you can see a partial articular injury. Okay, so lateral cortex is intact, posterior cortex is intact. It's really just anteromedially. So that you go in, this is similar to tibial plateau, right? You don't need locked plates. You just need standard fixation, buttress fixation. Here you can see the small spring plate anteriorly, and then this is actually a very old style cloverleaf plate out of the small fragment set. On the medial side, non-locked fixation, buttressing, and anatomic reduction. Lots of tips and pearls. Remember, when you're reading these, really focus on these pearls and pitfalls and tips as you get through the section. And then here you can have there's some cases at the end of the chapter going over some select complications. Here's a case of a non-union broken plate. This is a very old case that had multiple surgeries before she got to this point, actually, and with both arthrosis at the joint, non-union at the metaphyseal region, and multiple previous surgeries. She was actually treated with a hindfoot fusion nail, and patient was finally able to ambulate, go back to work after many years of disability. Here's another case, patient with ORIF, distal tibia, non-union, treated with a revision ORIF, bone grafting, goes on to heal. This particular case, remember, infections unfortunately in the distal tibia can happen. This patient had an infected open distal tibia fracture. Eventually couldn't get this infection to go away, had a bone transport, right? So resection of the infected bone, probably about that much down there. Transported down here. You've got nice regenerate bone you can see in this area here. Fused down here. There's actually a broken X-fix pin in there. Some of the retained screws. Ankle went on to auto-fuse, but this patient was able to ambulate on this once that was done. Okay, here's an example of malunion, right? So this was treated perhaps with external fixator, percutaneous, or maybe not percutaneous screws, but some retained screw in there. You can see here fixed with a sort of closing wedge, osteotomy, compression, and was able to get the ankle slight overcorrection here in order to help get the foot back to plantigrade position. So obviously a lot of complications you could potentially face with these injuries, so hopefully this chapter helps better enhance your understanding. Thanks.